Hello, I'm Eleni Evstathiou. I'm a medical oncologist from the MD Anderson Cancer Center in Houston, Texas, and we're here in Chicago. We're just wrapping up ASCO meeting, and this discussion is going to focus on new data that has emerged and will contribute to shaping, or let's say, improving maybe our practices or not. And I will let my esteemed colleagues introduce themselves. So, Nicolas.
I'm Nicolas Motet. I'm a urologist based in France.
Hello, I'm Marie DeSantis. I'm a medical oncologist based in Berlin in Germany at the Charité University Hospital.
Hello, I'm Andrew Armstrong. I'm a medical oncologist and associate director of the Duke Prostate and Urologic Cancer Center.
So, as you can see, we only have one representation from urology, but if there's somebody who can put us in our place, it's the person who is mainly involved in making the guidelines for the European Urology Association. On the other hand, there are 3 oncologists, but again, the balance is there because we have 2 US-based, and I can still say that I'm part European, part United States, but come on, Maria. You're the whole of Europe right now, so you have experience for everywhere. And I think that in the discussion, it will play an important role. So we decided to discuss starting from what has become more of the interest of the day, which is the hormone-naive disease, probably because we believe that there may be an incremental change that may lead to an improvement in the lives of our patients, and we're getting a lot of data along these lines. Now, there were some data that evolved today, and we saw it reported in the oral session about using docetaxel in this adjuvant setting. I would actually ask Nicolas, as a urologist, because the trial had radiotherapy involved, to provide the first comment on the study that was unfortunately negative.
Well, the study was negative as a whole. The first comment is that I was surprised by the design. Combining intermediate and high risk is unusual. Especially treating high risk with just 1 year of ADT is far away from every guidelines. Having said that, the trial as a whole is totally negative. The complete overlap of the 2 curves. And I remember there was a trial presented, I think, 2 years ago, when there was a clear trend suggesting there might be a benefit. It was a little bit early, but this trial at least is completely negative.
So from the US side, Andy, do you think we're missing an opportunity to identify a subset if we're going towards these types of designs?
Absolutely. So you're referring to the RTOG 0521 study. It's still not published, but it's actually been incorporated into some of the NCCN guidelines as an option for men with high risk, very high risk disease. And that's based on a survival benefit that was seen in the adjuvant setting with 2 years of ADT in very high risk men, very different than the Scandinavian study that really enrolled mostly intermediate to lower high-risk men. And in that setting, they gave inadequate hormonal therapy, as you mentioned. The RTOG study gave 2 years, and the 6 cycles of docetaxel did improve survival. It was really just incremental advance, 4%, at 10, 15 years. But for a young patient with aggressive prostate cancer who wants to do everything possible to be alive at 10 years, this should be an option. Now, what's even more intriguing is some of the abiraterone data in that STAMPEDE trial. Abiraterone has kind of replaced docetaxel for many patients who have chosen a oral therapy. So LATITUDE and STAMPEDE have moved that conversation more towards potent AR inhibition. But I think what's most intriguing is STAMPEDE allowed patients getting radiation in the curative intent setting and shows phenomenal activity, not yet survival, but relapse-free survival that is substantially delayed with radiation and 2 years of ADT with abiraterone.
I could not agree more, but again, we would have to say that there was similar incorporation in STAMPEDE docetaxel. So Maria, to you, and for the people who would go back tomorrow to practice and see a 52-year-old man with a Gleason score 9, high-risk locally advanced disease, it's a challenge. And let's say a low PSA producing, I would be inclined to follow your guidance with regard to the data of the STAMPEDE, but again, you also have docetaxel data. So you would probably do a multidisciplinary meeting in Germany, as we would do everywhere. What would be your inclination for such a patient?
So you mean a patient with metastatic hormone-naive disease, or in the non-metastatic, localized high risk? So in Germany, I think additional docetaxel or even abiraterone would be too early to recommend. I think this would be not our first choice for these patients in the MDT. So I think we would need to wait for the results of the or longer follow-up for the STAMPEDE trial, for example, to get the data and then base our recommendations on level 1 evidence.
Absolutely. So I think we would agree.
And
Go ahead,
NCCN guidelines agrees with that, although it was a controversial discussion.
Sure.
The relapse-free survival was 90% in the abiraterone treatment group, but overall survival not yet seen. So do you wait for that, and what do you do for the patient in front of in your office the next day? We do have clinical trials. Clinical trials are always recommended to answer that survival question. We have many potent AR inhibitors moving up well beyond the metastatic setting. And I think enrollment on those trials will be imperative.
So the jury is still out. We can't answer this question. We're trying to do the best for our patients. And I mean, you worked me up to what I presented today, which had to do with those men who are relapsing. And I think, because you voiced your concern about just trying to improve the PSA relapse-free survival. So just to give you a short overview, what I presented was one of those trials that is looking in the intermittent use of androgen deprivation, going back to the Klotz school, the Canadian school of trying that for those men who don't have metastatic disease in an effort to improve quality of life and shorten androgen deprivation duration. As a phase 2, it was not addressing the big questions. So we were just focused on this part, and I think that's what we were trying to show. No difference in testosterone recovery, a delay in the PSA recurrence.
A significant one.
Well, but the thing is, we want to get to the point where we don't even have that. And that's why the results of these adjuvant treatments will be very important, and the molecular profiling of these agents. So having said that, though, going to the metastatic setting, we had the opportunity to try to a little bit get more information in the follow-up from the LATITUDE trial during this meeting. And I know, Maria, you have an interest in that. And obviously, this will make us be a little bit more precise with our patient. What was your thought in the posters presented?
Well, I think it was interesting really to see the longer-term follow-up of the LATITUDE trial. And here I want to bring in something that was mentioned in today's educational session, because it is actually not so much about if to get abiraterone or docetaxel, for example, in this patient population, as unfortunately we still don't cure the patients, but in whether to start with AR-targeted therapy like abiraterone in the hormone-sensitive setting, and then what to do next. Mostly chemotherapy comes as the next step. But now in the follow-up of the LATITUDE trial, we saw the post-progression treatment data, which was pretty interesting. Firstly, we saw that, not unexpectedly, the need for additional treatment was significantly delayed on the abiraterone arm, like tripled, nearly 3 times as many patients on the ADT-only arm were in need of subsequent life-prolonging treatment. So this was good to see, but was not unexpected. There was a crossover option, so patients were unblinded, and 60 patients, which is only 10% actually, crossed over to abiraterone from the control arm, from the ADT arm. Most patients, interestingly, received docetaxel in both arms. And I was pretty surprised about that. I would have imagined that most patients would have wanted, and most physicians would have given abiraterone or enzalutamide at progression, but this was actually not the case. So I think this was really interesting to see, and the long-term follow-up is always very important in these huge-scale trials to inform our further treatment decisions and to learn what is really going on in the community.
So Nicola, you voiced a concern on that, but also before going to that, the fact that you got more patients going on to docetaxel and the comparison there. But do you think, did you discuss at all with the authors if they found out whether it was because it was symptomatic progression and there was a concern about the window of opportunity? Was there any discussion regarding that? No.
There wasn't. The only thing with this is that Latitude and Stampede are by no means early versus deferred ABI. It's early ABI versus nothing initially,
Correct.
followed by life-prolonging agent, whatever. It was mainly docetaxel. I don't think it lowered the value of the evidence. The evidence is very clear. The benefits remain. So there's no discussion on that. But it's a pity, methodologically speaking, that it's not early versus deferred. Same thing with docetaxel. It was not early versus deferred.
So going back to that, we had a very nice meta-analysis presented in Annals of Oncology. There were actually 2 papers, and the sides paper was the one that was actually using the contemporaneous arms within Stampede. And that was the only one that we even saw in last year's ESMO that showed, at the end of the day, survival is the same, whichever agent you use, especially when you don't have any predictive markers. Now, we have both agents available in the United States. Very soon, from what I understand, the rest of the world, abiraterone will be also available in the hormone-naive space. A patient walks in your office this time. Metastatic hormone-naive prostate cancer, how do you decide?
It's a great question because I face it on Thursday. The issue and the big concern is the early use of these agents, while they improve survival, create a resistant tumor, and how are you going to treat them subsequently? But the good news is that early treatment seems to provide a greater magnitude of benefit than waiting for castration resistance. We know that castrate-resistant tumors are more heterogeneous. They have more genomic evolution. They're very hard to treat. And the survival benefit on an absolute level is measured in 2 to 3 months versus 1 to 2 years with upfront either docetaxel or abiraterone. So I think as long as you pick one, you're doing a service to your patient. Now, some patients want to get it over and done with, 6 cycles, 18 weeks. Docetaxel makes sense. From a cost and health economics perspective, docetaxel is cheap, it's generic. Abiraterone, while it's becoming generic, is oral. In the United States, some patients cannot afford it, even the copays. And so that really plays a real important role in the decision making because it's not based on efficacy. It's based on, can you get the drug? Can you afford the drug? Can your health system afford the drug? The toxicities clearly favor abiraterone, although you're on abiraterone for 3 to 4 years versus docetaxel, just a short amount of time. Docetaxel, neutropenic fever, abiraterone, more metabolic, mineralocorticoid, cardiovascular risks. So it's more based on comorbidity, preference, and health economics, I think.
Nicolas, would you agree? From the European perspective.
Completely. From the European perspective, the only difference is to pay for the drug. In my country, patients don't pay anything for the drug. So either the drug is available, that is, they are reimbursed.
They pay for the drug.
Yeah, but whatever you do, you pay the same taxes.
Yeah.
Society makes the decision, though. Yes.
The state decides, we pay for the drug in this situation, we don't. If they don't.
Now, some interesting ongoing questions are alternatives. You know, if one is good, is 2 better? And the PEACE studies are answering that. And
right.
enzalutamide is emerging within the next year. We'll hear about 2 phase 3s with that agent. Of course, that's expensive as well, but involves no steroids.
I am getting a little bit concerned, and that's probably just me voicing that we're becoming a little bit too comfortable with the oral agents, and we may lose a little bit of the monitoring that is needed. And that's my concern. I think then it falls upon the agencies that are involved in education to provide that to the providers.
Absolutely.
So moving on, we did not have any wow effect this year at ASCO, right? We got it last year. Well, we've been privileged. But we saw some data come forth from therapeutics area in the metastatic castrate-resistant prostate cancer arena. I think that what baffled me was the data, and I'll ask you, Andy, your thoughts on it, that was just presented by Noel Clark. So this was not as expected. The numbers are small. What Noel presented was a study that actually looked at the combination of olaparib, a PARP inhibitor, plus abiraterone acetate versus abiraterone acetate. And I'll let you talk a little bit about it and your thoughts as compared to other trials.
Sure. So the idea behind the abiraterone olaparib trial was that the AR regulates homologous repair. And Karen Knudsen and her colleagues, Charles Sawyers, have published good data supporting AR regulating DNA PK as well as other homologous repair enzymes. That underlies the fundamental basis for how ADT improves survival with radiation, for example. So the idea is that if you're impairing DNA repair, we can leverage that with a PARP inhibitor to fully engage DNA repair, block it, and kill more cancer cells. And so they enrolled patients that were not selected based on homologous repair. In fact, they didn't even measure it prospectively. They had to go back and look at it. And interestingly, the patients who didn't have homologous repair defects did better. So that was
so
shocking.
strange.
That was shocking. And, but subset analysis, very tiny number of patients with biomarkers. It was not a precision medicine study. It is launching the PROPEL study, which is the next phase 3 version of this, but it would be much bigger, much more well-powered. The big concern about this trial is that there was safety concerns. There was cardiovascular risk. Anemia is significant. And I would like to point out an ASCO poster that I just became aware of yesterday where it showed olaparib caused red blood cell folate deficiency. And that's an interesting mechanism. It's Achilles heel of a PARP inhibitor is anemia. And everybody just chalks that up to it, oh, it's a PARP inhibitor effect. But why is it causing folic acid deficiency? Can you actually correct that and fix that problem? Measure it and see if that can. Now, it may be the folic acid supplementation does something bad to tumors. Tumors may be promoted with folic acid. So it's just an intriguing toxicity. Cardiovascular risk with hypertension from AbbVie, maybe the added anemia with olaparib may have led to the higher cardiovascular events. So there was no survival benefit.
Oh, yeah, we're scratching the surface of
Right.
something we do not understand from all perspectives, even how to tackle it.
Yeah.
So a lot to
A
come
lot
forward.
to come, yeah.
So what were your, and it was a very disappointing session on immunotherapy for prostate cancer. Now don't get disappointed, we'll get there. It's just that we haven't figured it out. So Maria, your thoughts on the pembrolizumab study?
Well, the pembrolizumab study was actually pretty disappointing, as you just said. The response rate was very low, and the presenter actually, Johan de Bono, tried to find out the real subsets of patients that would respond, and it is actually the case that there are the patients who are responders, but it is still very difficult to define them. We still do not know who would be the patients who would respond. So I think it is a little bit also early days for immunotherapy. We have had quite some negative randomized trials with immunotherapy, and now a single-arm study. Sorry. Prostate study, for example, today. But with pembrolizumab, which is pretty well tolerated and would be a nice drug in the later stage setting, we do not see the effect that we actually wanted to see. Yeah.
So I'm going to turn it to you because you're going to be the one closing the session, because we're all getting to one point. We need some kind of markers.
Yeah.
And you presented a wonderful work on today. So if you could provide us your insight. This was work on the two major assays that are used for ARV7 detection and a real big unmet need. And I loved it. I think it was the highlight, truly. I mean, this is what we need moving forward. So your thought on that and your work.
So the theme of ASCO is precision medicine. And I think you heard from the immunotherapy trials that if only 6% are benefiting, we shouldn't give it to 100%. You know, MSI high tumors should get it for sure. It's already approved. And then maybe we've learned about a new subset of CDK12 mutant patients, and that'll be coming out in Cell next month.
Right.
But our study was called the Prophecy study. This was more, can you predict standard of care therapy, AbbVie, Enza? We know that there's cross-resistance. I think that was one of the most disappointing things of the whole development of these novel AR therapies, is that you really get one shot, not two. There are patients that have responses to subsequent oral therapy, and we're excited about them, but it's certainly not 100%. It's probably under a third. And so if you're using those agents, that's cost and expense to society, toxicities to patients, where 2/3 of the patients are not getting a response. So our study was really dedicated towards men with CRPC who were getting standard of care Abi or Enza, and it used a liquid biopsy approach to try to predict the future, thus the name prophecy. And so the ARV7 assays, there's really two that have both analytic validity and early clinical validity. The analytic validity is very important for these assays. You need to set a threshold. You can't just do RNA sequencing and measure it and say at an arbitrary level. You have to have and these are circulating tumor cell assays, not whole blood assays. So we're enriching for cells, we're measuring the splice variant that has a protein product. This protein product does not bind to the drug, so mechanistically it's understandable that the drug's not going to work if you have a tumor dominated by a ligand-independent molecule like ARV7.
So I'm going to get to the punchline.
Yes.
Who's the winner? Is there a winner?
Great question. I personally think that both won. So officially,
It's being very politically correct.
the Hopkins assay predicted PFS, met its primary endpoint, predicted OS. In fact, it predicted OS even better than PFS. There were some false positives. So there were 3 patients that had a confirmed PSA decline, and so the response rate was not 0, okay, if you were ARV7
Sure, we
positive.
expected that. The Spanish group had talked about.
And so I think we need to work out in those patients, was at very low levels of ARV7, maybe we can improve the assay a little bit so that it's a little more perfect, but it's a great start. I think it's worth ordering that test if you have this therapeutic dilemma between a second AR therapy or a taxane or enrollment on a trial or
Go to this
radium.
gentleman to be the critical reviewer.
The second,
prognostic or predictive.
Yes.
He's going to tell us.
The second assay was epic.
Yeah.
It was 100% in terms of the positive predictive value of lack of response. So nobody responded if it's positive.
So you're pretty safe
that validates Howard Scher's work. It's exactly the same data.
Right.
And what's interesting about this predictive prognostic question is that ARV7 does go up with progression, so suggesting maybe it is a driver in some patients. But in some patients, it may be a passenger. So in cell lines, you see that as well. Sometimes when you knock down ARV7, the tumor's happy.
And the verdict, prognostic or predictive?
No idea yet.
No idea. There needs to be a little bit more work on it.
Absolutely.
What we know is they're bad performers.
I think there's heterogeneity.
But this
to
is
it.
progress. This
Yes.
is
Yeah.
better than where we were last
It
year.
is.
It's going as in that direction.
And we are making then progress, and that's what I wanted ended up, because you heard the disappointment about immunotherapy. And we'll be sitting here next year saying very positive things with regard to immunotherapy, I'm sure. Thank you very much for your participation and attendance. Have a good night.